better see all your hands pretty much. How about any of you encountered mental illness in your family or in your own life? Okay, so mental illness, mental health disorders are prolific, and especially in your line of work, you guys are at the tip of the spear on many levels. Mental illness, 75% of mental illnesses start before age 24. So the work you're doing is actually the most important of all the service providers in my view for mental health, because you are at the very front lines. So Jackie St. Louis and I are happy to be here today. We work together in a partnership, actually. The Union Gospel Mission and the Metropolitan Improvement District have joined forces to do outreach, and you may have seen the yellow-jacketed ambassadors that ride around Seattle on their bikes. They are kind of the eyes and ears of downtown Seattle, the streets, and so they're wonderful in identifying folks with mental illness, chronic mental illness, and then directing those folks to our attention. So we have a great partnership, and then Jackie came on 2 years ago, Jackie? 2.5 years ago. And we have this robust outreach program that just grows and grows, and it's filling a big need in Seattle. So here's what we got for the agenda today. We'll do a little more welcoming, but we're going to talk about some facts and figures. We're going to look at the Adverse Childhood Experience Study, the ACE study, because a lot of you might know about it, but it needs to be talked about more. And I don't know if you've heard, the Seattle International Film Festival has a film coming out next week called Resilience. And it's by a gentleman who did a film, Paper Tigers, last year. And it's about this ACE study. So it's good to see that it's getting some attention. But we're going to talk a little bit about that. Just how can we change the story of mental health? I'm going to lead you into some ideas about working with depression and suicide, mood disorders. Jackie's going to talk about psychosis. We'll both be sharing together with you. I was just certified to teach a class called Youth Mental Health First Aid, so I'm excited to bring you some of those activities today. And we're going to look at some case studies, and Nicole had a lot of questions. She sent a survey out, so we want to make sure you don't leave here without having your questions answered. If you don't get a good enough answer, then we'll give you our card. You can follow up with us. So, again, I think it's important to point out the core reasons why we do this work. And I was looking at the mission statement for New Horizons, and I'm sure it's similar with Roots. And it's really about relationship, right? It's about coming alongside people. I love the mission statement that you have there. And reading about how Father Don went across the street from Bread of Life to the donut shop with New Horizons and just started sitting down having donuts and coffee with the youth there. And that's the core of what we do. It's the core is letting people know that have mental illness that they matter. That's kind of the core of all our relationships, right? To let that person know that we love them, that they matter. And so how do we do that? Well, one of the barriers is there's a lot of myths about mental illness. Those myths will be dispelled. I imagine a lot of you already get that, have been dispelling those myths. And one of the fundamental things, since this is an introduction, mental illness is such a broad topic that it would take, well, it takes an 8-hour course just to do mental health first aid, and it would take several days to cover it in depth. But today, I hope you leave here just getting an understanding of how to listen well. Be a really good listener when it comes to someone with serious mental illness. So we'll talk about some of those principles. So again, thank you for being here, for the work you do. I'm a big admirer. When I used to work in the emergency room, I was a social worker for 10 years. The first 5 or 6 years when a young person would come in that was suicidal or was in crisis, my heart would beat a little bit faster than an adult because it was a little bit more challenging in my view. And so I admire what you do, and it took me a while to kind of get it, to kind of get what Father Don got. Is you just need to be genuine and to go where they are and be a good listener. So I started to enjoy it a lot more. As far as working in the mental health field, there are some folks in Seattle who think they have the territory when it comes to mental illness. Don't encroach on our professional skills. And Jackie and I have run into some of this, and that's not my philosophy. My philosophy is don't do harm, but get involved. Don't be afraid to step in and greet someone with a mental illness. I've heard it said at meetings even, well, you might confuse the person. I don't agree with that. Even if you do confuse them, if you're genuine and you're accepting, you have empathy, you're going to help that person. We need to multiply our services for folks with mental illness. We need to have more people willing to come up and companion and befriend. So I hope you understand that this isn't just for specialists to talk with folks with serious mental illness. Now, they may need mental illness specialty care eventually, but as far as engaging them, we all can do that. So I'll tell you a little bit about how I got into the field. I woke up at 4 o'clock in the morning, not this morning, it's about 26 years ago, in my dorm room bed at SPU, and there was water dripping on my arm. I thought, what is that? Is there a leak or something? And I looked, kind of opened my eyes, and it was my roommate. He was soaking wet from head to toe. And I said, Don, what are you doing? It was 4 in the morning. And he said, I was just at the bottom of the ship canal. I went down to the bottom and laid in the mud, and it was so good. I said, Don, why? Is it some sort of cruel initiation? He was on the crew team at SPU. And Don, I got assigned to SPU at the last minute, and I got assigned a roommate. And I was a little nervous about it, but I found out that Don was probably the best roommate I ever could get because he was friendly. He introduced me to people. He made me feel at home at the school. He knew all the arts and culture around town. We'd go to plays together. But 2 months into our relationship, our friendship, this happened. I said, Don, why did you go down to the bottom of the canal? He said, well, the voices told me to. It was the first time I encountered serious mental illness. He had a diagnosis of bipolar I disorder with psychotic features. And I didn't know what to do. I journeyed with him from that point and found out that his family had basically left him behind. He was estranged from his family because of his illness. His work, there was just this long trail of failed work attempts. Shortly after this episode, he had to drop out of SPU again. He'd already had to drop out before. And I just saw this trail of debris and trauma, really, just from his illness. And the biggest thing I saw was loneliness and isolation. And so I decided, he had an 80-year-old grandmother who was the only person in his life. I said, I'm going to be one person in his life. I'm just going to do what I can. So I started to go to appointments with him. I visited him in the hospital when he got hospitalized. And I started to see the areas of our mental health system that are so broken and so scarce, the things he needed for help. And so I awoke to this new calling. And one day I was with Don at a halfway house, and we were across from a mental health center. Don said, I was saying, I need to volunteer somewhere. And he said, well, you should go volunteer over there at Sound Mental Health. So this was about 27 years ago. I said, I don't know what I could do, but I'll go over there. I signed up, and they signed me up with a clubhouse program, playing basketball every week with folks with serious mental illness. And I loved it. Just to see the faces of people come alive from their states of schizophrenia or depression when we played together as a team. So I was hooked. The health problems that can result from eating disorders they can be lethal. They're major. So it's real important to be aware when you see that, notice signs and symptoms, and know what to do, know how to refer to treatment. Okay, the last one, I think it's the last one. No, there's 2 more. Bipolar disorder. Anyone? Okay, Mark.
Youth with this disorder experience times of depression mixed with episodes of normal mood and mania, elevated mood, increased energy, and overconfidence. Youth may experience more rapid mood changes than adults, appear more irritable or aggressive, and engage in increased risk-taking.
Yeah, with bipolar disorder, you often see grandiosity as part of the delusion. And with my roommate, Don, he would get up on a table like this in Gwynn Commons at SPU and make announcements to the student body. He just believed that what he had to say was grand and ultimately the most important thing people needed to hear. And so that's a common symptom of bipolar disorder in a manic episode. Okay, with depression, who has that? It's the last one. Who has that placard, not who has depression? All right.
A mood disorder that affects 9% of youth ages 12 to 17, characterized by an unusually sad mood, loss of interest and enjoyment, and for some, irritability and a tendency to snap at others.
Thanks, Angie. So yeah, irritability is a component with youth that you see more with depression as opposed to withdrawn, but you can see withdrawal behavior too. Now, those percentages that Angie read, I think it was 8, did you say 8 or 9%?
9%.
Okay, this comes from a study that was done in 2010 with household youth, not homeless youth, not incarcerated youth. So you guys work with homeless youth and incarcerated, so think of the numbers that we're looking at in New Horizons and Roots. So the discussion is obviously important because they're common. There's a lot of stigma. And one thing I've noticed with youth is it's becoming a little less than it used to be. Folks are sharing more openly about mental disorders, which is good to see. But still, people are not very well informed. I find this especially when I talk in churches. Folks still sometimes think that it's a spiritual problem. And what do you guys think? Is it a spiritual problem, a moral problem, a character flaw? It's a brain disorder, right? Absolutely not. Now, can you still have moral issues if you have a mental illness? Yeah, we all do. We're all fallen in some way. We're glorious ruins. Another issue is help is not always on hand. And I think that's part of the reason Jackie and I were called into this work. We're funded by the Downtown Seattle Association and UGM because we need more help. People often don't know how to respond. One of the main questions Jackie and I get asked is, don't you feel afraid out there talking to people on the street? And the answer is no, not with folks that have mental illness. Folks that are intoxicated sometimes because the inhibitions have been eradicated in some cases. But no, I have not felt in danger since I've started this work, working with folks that I've identified as having mental illness and just needing a companion. So there's a lot of flaws, myths about violence and mental illness. And the fact is, folks with mental illness are harmed 2 to 3 times more than the general population. They're more vulnerable. There was a study done by Duke in North Carolina back in 2008. And actually, the same percentage of folks in the general population that commit assaults, violent acts, is the same within the population of those that have mental illness, 10%. So when you look at violence, you're looking more at folks that have behavioral, personality issues, substance use issues. And then there's folks that have untreated mental illness that have a delusion where and it just continues to grow because they are isolated, where they need to protect themselves. Usually that type of violence is rare, but we see it on TV a lot. It seems like it's really common. But if that does happen, of course it happens. And another issue why this is important is people often don't seek help if they have mental illness. Folks often don't know their own illness. This term is called anosognosia, And our laws don't really adequately address that because we wait for people to volunteer to get help, even when they're declining. And we'll look at a case study later Jackie's going to bring up of how this is a real barrier to saving people that are out there on the street. So let's just get on the same page for a definition here of mental illness. It's a condition. It's a diagnosable illness that affects a person's thinking, emotional state, and behavior. And it disrupts the person's ability to work, engage in everyday activities, and this is probably the most important one, engage in satisfying relationships. That's where we can play a big role. And there's a duration there too that's not shown on that slide, but it has to be for a certain duration. Now, we're not going to learn to be clinicians here. I know some of you are, which is good. We don't need to learn that, but just so you're aware. In order to decrease stigma, there is a movement to change the term, especially in research circles, to brain disorder. And it's exciting to see some of the studies they're doing on brains, brain research. That's a pictograph or picture of a cell in the brain, a three-dimensional. Anybody know what that cell is? What it's called? Neuron, good. Guess how many you have inside your skull there, in your brain? Just take a wild guess. Nobody knows for sure.
A billion?
A billion? It's a good guess. It's a little higher than that. So estimates range from 100 billion to 400 billion. So that's about the size of the stars, the number of the stars in the Milky Way galaxy atop your head, in your head, atop your shoulders. So we're like galaxies. It's surreal. And what's even more surreal is that to form a thought, even a knee-jerk reflex, it requires millions of those neurons to fire off and send messages together in concert with one another. So we wonder, how do brain disorders occur? Well, how do they not occur when there's so much going on? What I say is, praise God, I am fearfully and wonderfully made. So brain research is a huge study. It's like astronomy in some ways. It's so vast. But they are making progress, and it's exciting to see what they're doing. They're learning the etiology of brain disorders. Biology is one way that a mental disorder begins. Neurotransmitter dysfunction, those are the little chemical messengers between those neuron ends, those tentacles, where they send messages back and forth. There's about 30 different neurotransmitters that they know of. Can anybody give me an example of a neurotransmitter in your brain?
Dopamine.
Good, serotonin. What's that? Another one?
Dopamine.
Dopamine, right? Common ones. Yeah, there's many others. So medications work to control the uptake of those neurotransmitters. But also, adverse childhood experiences are a big part. We're going to talk a little bit about that. Genetics, mental illness can be hereditary. And so I already asked you this. I like to put this in several slides just to hammer the point. And I loved what Randy Revelle, our former King County executive, said. So, he's a real honest guy. And he does a lot of speaking engagements where he talks about his manic episode. He had psychosis while he was running for King County executive. He thought wolves were coming after him in his house, but he still managed to win that election because he had a good team of people supporting him. But it was harrowing, the way he describes his journey. So just some more prevalence stats. I just want you to know that mental illness has a huge impact. I think you guys already know this. The reason we're going to talk a little bit about suicide here, and I like the document that you guys used, that Nicole, you gave me, the suicide prevention list. I'm going to hand that out again, make sure you have that. It's still rising. Among the top 10 leading causes of death in the US, suicide is still rising. So there's been a lot of work done on this, and it's good. but we just need to keep carrying that forward. Don't be afraid to ask. That's going to be the takeaway point. Don't be afraid to ask directly if someone's suicidal. So youth prevalence, this slide shows how prevalent anxiety disorders are between ages 13 and 18. Severe impact, so mental disorders are on a continuum of disruption, so they rate it mild, moderate, severe. So severe impact is still higher than most medical conditions that we pay a lot of attention to, like asthma, diabetes. But do we pay enough attention to these in our youth? I don't know. When you think of it, think about it, 1 in 5 experience a severe mental health disorder. And the reason substance use isn't over here is because it's just considered that's severe. If it's being used because it's before the legal age, that age. So we'll kind of focus in on depression. So this breaks it down with gender. Why do you think women experience depression at that rate compared to males?
Male oppression.
What's that? Male oppression? Okay. What else?
Maybe internalizing it as opposed to externalizing it.
Okay, maybe more internalization. Maybe this survey that was underreported with males. These are good ideas. What about ages? When you look at the ages and the prevalence, 3.9%, 12, then you go up to 16, 11.6. Then it drops down a little bit at 17. Any thoughts on that? Okay.
Puberty?
What's that?
Puberty?
Say that again.
Puberty.
Puberty, okay, yeah, puberty is going on. Lots of hormonal changes, yeah. Lots of chemical things happening with youth, in the brain. So this takes us to our next exercise. So if Jackie, if you could help me hand out some of these, and maybe Nicole, you could help too. What I've got, I'm going to hand out some disorders, piece of paper with disorders on it. And what I'd like you to do when you get yours, to stand up and go to an age category where you think the onset is, the range of onset of that disorder. So over here we have ages 8 to 12, so front right. Back where Nicole was, we did have,
I took it down because I didn't know. I'm sorry. I'll put it back up.
but I think it was 12 to 17. That's okay, Nicole. And then over here we had an age group on the poll. It was 18 to 25. And then up here we have 25 to 35. So this exercise is interesting. I think you guys might be surprised about onset of mental illness. Yeah.
When it starts.
Yeah, sorry, when it starts. So when you first see a diagnosis. Okay, go ahead and take a few minutes and then recognize signs and symptoms that might be a mental health disorder in youth.
Teenagers are grumpy and moody.
Exactly. There's so many mood changes. Somebody over here said the hormones are just really changing rapidly, and that does have an effect on mood. So we can all see from that exercise that mental health disorders, even among the ones that Jackie and I work with adults on the street, they have their onset with the folks you're working with. Okay, that's the big takeaway. So thank you again for working with folks in this age range. So I want to kind of go through these slides quickly, but I just want you to be aware of this adverse childhood experience study that was first done in 2003, and then they did another study in 2010. And then we're going to talk about what the 40 developmental assets are, because I think these are things that we can control as youth care workers, case managers, all of us. So here's the 10 different types of ACEs, adverse childhood experiences. And many of us in this room have experienced a lot of those. You see? So there are 3 categories: abuse, neglect, and household dysfunction. And so basically the ACE study was they did a survey, a simple survey. Did you experience this? It's just a 1-page questionnaire. You can take it, it's online. If you go to Google and type in ACE study, National Institutes of Mental Health. And the CDC put out this statement a few years ago. It says it's critical to understand how some of the worst, not just mental health, but health and social problems in our nation can arise as a consequence of adverse childhood experiences. This is finally finding its way to movies, documentaries. So Seattle International Film Festival, I recommend that film called Resilience, where it talks about this study, because it is important that we know this. The first study, I guess it was 1997, it was actually a childhood obesity study, but the results that came back were alarming. In fact, the doctor who ran the study, I can't remember his name right now, does anybody know? He broke down in tears when he saw the results. It was that overwhelming and compelling to him, the results. That just neglect alone, children who experience neglect alone were 12 to 16 times more likely to have a homeless experience, 36 times more likely if they had both abuse and neglect. And then they went ahead and they did another study that was more comprehensive with 17,000 participants that were part of the Kaiser Permanente network of insurance. And 2/3 of those folks had at least one adverse childhood experience. Nearly a fifth had 4. Almost a quarter of all the women reported childhood sexual abuse. So it's very common, very common. What we can say to ourselves and others is we're not alone. So the likelihood of adult suicide attempts increases by 3,000% with an ACE score of 7 or more. If you have a score of 4 or more, you're 460% more likely to have depression. And 7 or more, there's a 5-fold increase in the risk of reporting hallucinations. So just real briefly, we'll talk, I think Jackie's going to talk more about this too when we talk about trauma, is why? What's going on, even biochemically in the brain, physiologically, when we experience trauma? This is kind of the sad part of this talk, but the good part's coming. Brains change when they experience trauma. It's like if you're running from a bear and your brain gets bathed in epinephrine, right, adrenaline, and you're running and your body is secreting all these cortisol hormones, stress hormones to save your life. But when you grow up and have a childhood adverse experience like that that's ongoing and the trauma keeps getting triggered, your brain experiences those same chemicals, and it's toxic for the brain, not just the brain, but for the body. It causes health problems, it causes immunological problems, mental health problems, just talking biochemically now, but let alone all the other things socially and the shame. But just we know that the brain changes from trauma. So that's the hard part to hear, but the good part is this, that we're resilient, and that's what this documentary is going to show, is how resilient people are and how we can enhance resiliency. So we have a friend, Jackie and I have given a presentation with, a wonderful lady that works at UGM, her name's Dawn, and she had a high ACE score, it was 8, but the thing with Dawn is she was blessed with all these developmental assets. So Jackie, would you mind handing out the developmental assets form? I want you guys to have one of these. I hope I made enough.
I have some upstairs.
Okay. But these are, the developmental assets are things that we can actually create opportunities for around our folks that we work with. And basically, I have one of them too. I'm just going to highlight a few. Thank you. It's support. So a caring adult is huge. And you guys get that opportunity to be a caring adult. Dawn describes this Sunday school teacher she had that was just so caring to her. It made a huge difference in her life. He believed in her. He told her basically like what we were saying before, you matter. And going to programs, like hearing Mary talk about all the programs you guys have, these are developmental assets. You're constantly making developmental assets, breaking bread together, eating together, emphasizing positive values, caring, equality, social justice. That's all being done here. So the neat thing about the brain and our bodies is they're resilient, especially with youth, but even adults, we're resilient, and restoration is possible. So if you look here, look at how many, if you have these developmental assets in play, look at the change of the percentage of poor outcomes, or in some cases, positive outcomes. It's a dramatic change with the number of assets. So as youth care shelters and mental health providers and holistic care providers, we need to be working on these. We need to be looking at these and figuring out how do we enhance that. And Jackie and I even do this in our work on the street where we go out to meet people, we look for ways to bring developmental assets in. One of the things Jackie does so well is he promotes people into leadership quickly because he sees where they're good and he gives them opportunities to lead. It's powerful. His team is one of the best teams in Seattle, and they came from places that were pretty harmed, pretty broken. So just real quick, recovery from mental illness is a reality. It's not that it can happen, it does happen. We see it happen, and we have to believe that even with our folks who have serious mental illness. You have to know that they can recover. And this is kind of for folks in churches. I liked how Rick Warren came out and said, let's start talking about mental illness. He lost his son to suicide. And we need to be taking the shame away from mental illness. This gentleman, Craig Rennebaum, is sort of who we modeled our outreach program after. And his main philosophy that I probably say this to myself every day when I come into work, is our word, our gentle gesture, our presence is medicine to people. It's a developmental asset. He wrote this book called Souls in the Hands of a Tender God that's just a wonderful book. So we can change the story of mental illness. We just need to be willing to sit and be present with people. A lot of treatment models focus on a person's illness, and they base their expectations on that. Like, okay, you have a severe illness, so your expectations are going to be here. And then we do harm reduction. I'm not saying all this is bad. I'm just saying it can be overplayed, and it can be taken to the nth degree where that's all that we're doing. And I think it's better to keep expectations high for a person, like Jackie does with his team, and draw out their gifts and talents. And that happens when you have an in-depth relationship with someone. You're able to recognize where they're strong and draw that out. And I know that happens here. I don't know why I put that verse there. I just love it so much. I just got stuck in it. But yeah, that's the gospel. Those are the people that Jesus wants. Yeah. If you're weary and burdened, come. He will give us rest. So I want to kind of breeze through this because I want to get Jackie. I want to get us a break and have Jackie come up. But these are some categories of risk with mental disorders. So it's hard in Washington State to get someone help who doesn't want help. And a lot of times folks with mental illness, they don't recognize, like that anosognosia we were talking about, they don't recognize that they have an illness. So how do we help? Well, in our state, if somebody says, I'm going to harm myself or kill myself, then we have the ability to put them in the hospital. Or if they threaten someone else directly, specifically, we'll look at some case studies, then we have a reason. But if they're not doing one of those two things, it's very difficult to get someone in the hospital. And it's sad because we end up just kind of shrugging or putting our hands up. What can we do? And we just walk on by. And a lot of folks on the street, they don't want services. They don't acknowledge they have a mental illness. And so the laws won't let us help them unless they have like 1 foot in the grave, basically. Very, very ill. So how do we help? We're going to do some case studies here in a minute to kind of walk through that. Yeah, question, Tish.
Yeah, going back to the previous slide, just wondering, because I've worked many years in Colorado, and I don't know what it's like in Washington, but in terms of harm to self or others, how effective are the hospitals? I mean, I know in Denver, it's like, even if you get someone into the hospital, there's oftentimes a long wait.
Yes.
You know, they have to wait in the waiting room for 8 hours. I mean, just
Good
the
point.
system's overloaded. You
It
know,
is.
so it's really hard sometimes, and they may just, a psychiatrist might only see someone for like 15 minutes and then dismiss them, and they're back on the street. You know, I don't know if it's the same here in
It
Washington.
is.
Yeah.
It is. Unfortunately, we're trying to change it. It's a crisis-driven system.
Okay.
Do you mind if I jump in?
Yeah, Jackie.
So I was working with a young female recently, and she'll be one of our case studies we've been working with for some time. She is diagnosed as bipolar and was in a manic state for some time. So she was admitted at a hospital. She had an incident where she assaulted someone with a knife. The police were called, and then they involuntarily committed her. I went to meet with her some days after, and she was in with the psychiatric staff. And I was really appalled, not only at just the approach that the professionals were taking, but how quick they were to dismiss her. And she had been sort of advocating for herself to getting into a mental health ward. And the assessment they made was that she was just not sick enough. And she said herself, do I need to pretend to be sicker so you guys would admit me? Because what was happening was she was going to be discharged onto the streets because she had no housing. She's manic, she is physically not doing very well. Her liver enzymes were elevated. And just the approach of the staff, I mean, it was really not empathetic. It was not person-centered, and I know they're overwhelmed. The system is overwhelmed. She was in the emergency room for the duration of the time that she was there because they just didn't have any beds to keep her. But our system is I don't think very responsive, and then we have to be very careful and cautious about the approach we take. Despite the fact the system may have been overwhelmed, I think there could have been much better treatment of this individual. So I think in that manner, we do fail folks.
Yeah, thanks. I was at a meeting yesterday with a woman who was just appointed director of OLALA, Chemical Dependency. Have you guys heard of OLALA? Inpatient, it's out in Kitsap. And we were going around the room, we were doing this little icebreaker activity where you share the most influential person in your life. A lot of people said their parents or famous author, but hers was a woman at the emergency room. After she'd been drinking and she was suicidal, she was brought in, and this woman just said one thing to her. And even as she shared it yesterday, it was 20 years ago, she broke down and cried. But the woman said, "Here, let me help you, you don't belong here." Everyone else just was like ushering her through quickly, like Jackie was describing, just no empathy. Just we're swamped, we're overwhelmed. But this one person stopped and she said that meant so much. Her saying, "You don't belong here. Let me help you." And so I tell that story to you guys to see the difference you could make in a person's life just by taking a moment of seeing who they really are and offering that to them. Like Craig Rennebaum, your presence is the best medicine. So we're going to talk about depression a little bit, and I want to give a lot of time for Jackie to talk about psychosis. So a lot of this material comes from mental health first aid. This is not a mental health first aid class, but I highly recommend you guys attend a youth mental health first aid class. They're really good. And I'll be happy to offer one in a few months. We can put it on the calendar, but it's an 8-hour course. You get a certificate that's good for 3 years. But you really dig deeper into scenarios and you get to work your skills, practice around the tables. Today you're just kind of listening and we'll do a few little activities, but it's a great course. This is the mnemonic for it. So like CPR has airway, breathing, circulation, ABC. This has ALGE, assess, listen, give, encourage, encourage. And those are the things you do. You don't have to do them in that order, but just to remember when you're with someone with mental illness, these are the things that you need to do. Am I always blocking you? Sorry about that.
The wall's blocking, so it's.
You want to move over? Sorry.
I can move it if I want.
Okay. So what I want to focus on today, since we don't have a lot of time to dig deep into ALGE, is the listening. So help starts with listening. How can we be better listeners? So there's 3 attitudes, and we touched on them earlier. Acceptance, genuineness, and empathy. And there's some nonverbal skills, and in mental health first aid we actually practice these. But these are just some things to keep in mind, and Craig Rennebaum talks about these in his book, and he talks about being present. It's just being attentive. It's having comfortable eye contact. Sitting beside someone is actually better than directly in front of them. And sitting is better than like standing like this. It'd be better if I was sitting next to Angie if we were talking about something important. Not
What if
fidgeting.
they're standing
Yeah.
and you're sitting? Should you stand up next to them?
It depends. If I just like to be lower than the other person. When I worked in the emergency room, they had those stools that you'd screw down and raise, and I'd always lower mine to the lowest setting so I could be down and talk. It's just less threatening. So yeah, those are, just touch on that quickly, and just a word. A good thing to say to someone when you're listening. Does anybody have an idea? What's a good phrase to say that lets them know? When we heard what the lady said to the now current director of a treatment center years ago. Okay. Okay, that's good. Yeah, I hear you. And just let them know that you hear them. One thing I like, and you can write this down if you want, is I'm concerned about you. That's a true statement, and it denotes care. Another thing I would often say when I first encounter people, and I still use this, is how can I be of help? One young person I talked to, I said that, and she started crying. And I thought, oh no, but she really appreciated it, because it was the first time somebody didn't just walk in and say, here's what we're going to do, we're going to do this and that and the other thing. First thing is open the invitation, put that on the person, let them tell you. That's part of acceptance. So we'll do this exercise. This is going to kind of defeat some myths about suicide. If I could have you stand up again. And so when you say, I'm concerned about you, you're basically saying, I don't want you to kill yourself. But that's hard, especially if it's somebody that's real close to you, which most people, you know, that would disclose this would be pretty close to. So I'm not saying this is easy, but you want to try to hold back any negative judgment. You want to check for these 2 things too, because that can really elevate the risk. And the main thing here on this slide is don't leave the person alone. Oh, sorry. Don't leave the person alone. Stay with them. Maybe ask for some help to make sure that there's people around. And really determine whether or not the person is actively suicidal, and and they need to maybe have a 911 call, if you could start passing those around. This is your own mental health first aid intervention toolkit that Nicole sent me, and I thought it was outstanding. First of all, it has algae on it, what we talked about earlier, so you'll be able to have that. But it also has some really good, clear steps to take when you're with someone who says they're suicidal, who to call, what to do. I loved it, so I printed it off for you guys. Yeah, don't agree to keep their threat a secret. Just repeat that I'm concerned about you. Yeah, that's the bottom line. I care about you. And this crisis line is, I hope you all have used it. 461-3222 is actually better to call than the 1-866 number, because if you call the 461, they can tell where you're at if they need to know. They need to send somebody more quickly. But what's great about this crisis line is you can call it with the individual you're with and have a conversation right there with them. And it's not 911. There's really kind, trained people on the other end of the line, and they can help guide you through next steps. So you're never alone with this crisis line. It's 24/7. I've called it probably over 1,000 times. I've gotten to know all the people down there. Say hi to Jenny. But it's great. They're a resource. You don't have to wait till you're in crisis either. You just call them to consult. I've got this person here I'm concerned about. Can you give me some ideas on what I should do? So back to Randy Revelle. You can tell I'm kind of into his speech. Just no one should be ashamed about your mental illness. If you do have a mental illness, which I know some of us in this room do, don't be afraid to tell the story about it, because that helps other people be more willing to share their story. And there's nothing really to be ashamed about here, but our culture has made it shameful. But when we think about it, like we talked about, it's a brain disorder, and there's treatment, and support helps, time and patience helps, then we need to be talking about it and telling the truth about it. Tipper Gore quote there. It still is a big stigma. Sorry, Jackie, I'm not giving you much time. I'm just kind of blazing through these slides. But I like this quote by Henry Nouwen. Hospitality is not to change people, but to provide a place where change can take place. And when I look in here in this room, that's what I see. It's open, there's a kitchen, it's clean, there's a pool table. This is where change can happen. Mental health classes. We have one this Saturday. If you want to sign up, there's space available. It's not youth, but it's adult mental health first aid. It's a good class. My colleague Ryan is teaching it, and Judy's, Jackie's colleague, and mine. You can go to the website Mental Health First Aid to find out more about the classes and how to be certified. It does cost $50, which is lower than what it normally costs. Yeah, and there's Jackie's number. You might get that later. But that's how you can get a hold of Jackie and the outreach team. If you want some of us to come out here and meet with someone with mental illness or housing issues, we can do that. So, any questions before we take a break? We're about to take a break.
I saw some people taking pictures of your PowerPoint. Would you be able to make that available to us so I can send it out?
I could. Yeah, I could email it to you.
Whatever you're comfortable with.
Okay. I don't think I put too many incriminating things up there. Mental health first aid, I modified those slides. They're real protective of their slides. So I might change those a little more, in fact, because I don't want to jeopardize that. But please come to the mental health first aid class. It's so rich. It's like, this is the intro, kind of the teaser. So it helped me, and I've been a clinician for 20 years, but it just kind of gave me a real synthesized way to approach people that was just helpful, especially with my own family, because it just sort of simplified things. I didn't have to think too clinical or hard about it. Questions?
Yeah, also, like, I think with suicidal ideation, do you think, like, because often in my work I find like, and this is, I'm wondering if you found this too, is that there's a comorbidity with homicidal ideation, oftentimes as well. Not always, but oftentimes if someone's been at that high level of risk, especially for several attempts and things like that, there's sometimes a tendency to kind of act, I don't care if I kill, right? Then I don't care if I kill others as well, because I'm going to die as well.
Yeah.
So,
No.
and we've seen that in the news and all that as well. So
I'm glad you brought that
Yeah.
up, because it's the same principle applies. You should ask directly, are you thinking about killing your brother if that's who he's focused on? You should go ahead and ask that. And I've asked it before. I've always kind of been surprised when people say, yes, I am, and I plan on doing it at 3 o'clock this afternoon. Okay, so that's when we get help. We stay with the person, we get help. Of course, I was in an ER setting most of the time when that happened, but even if you're not, if you're in a shelter setting, that's when you call 911, and you have a duty to a mandate to report that if you're a clinician. Go to your supervisor, report that. I'm sure you have a procedure in place at your shelters of what you do, but it's real important to ask those questions directly. And just let the person know, this is just because I'm concerned about you. All right, yeah.
I thought that was fascinating what you were talking about on the biochemical level, how repeated exposure to trauma releases chemicals in the brain that are toxic and poisonous.
Yeah.
First of all, what were those different chemicals the brain releases? Like just
So some of the biggest corporates are cortisol. It's a stress hormone. Our bodies, we have the hormone for a purpose, but it's not meant for long-term exposure.
repeated.
Lowers the immune system, creates all kinds of problems.
That's the big one.
Adrenaline or epinephrine.
Because then I was asking, where I was thinking, when we're talking about the homeless population,
Yeah.
specifically, kind of the mental health angle to it.
Yeah.
Kind of thinking like chicken or the egg.
Yeah.
Are there any like kind of recurring themes before, or is it kind of ramp up after someone becomes homeless? Is there any kind of thematic things you've seen in regards to exposure to trauma leading to that point, or does it ramp up after that?
It's a great point. I think it's why it's so hard to come out of homelessness. It's so complex. It's not just giving people resources, right?
Yeah.
It's relationship that we need to give people, and that was begin to heal and restore some of that loss of connectivity that happens with all that toxic stress and trauma. We can reframe it. We can create a different story, but only through the context of relationship.
Is there like a healing process that happens?
Yes.
Like a physiological
Yeah,
healing?
it's called resiliency, and it does happen. It takes time, but it happens. So we can't just, come with our resources and like we're clearing the jungle, but we're not taking the time to get to know these folks. And that's where Jackie and his team and my team come in. We're trying to facilitate that, but it's hard when there's a demand to be quick. It can really actually re-traumatize folks. So if you want to read more about this, I recommend Dr. Gabor Mate, M-A-T-E. He's a Hungarian psychiatrist that works up in Vancouver, and he wrote extensively about the questions you're asking, Jasper. He wrote a book called In the Realm of Hungry Ghosts that I recommend. It just kind of breaks down what's going on with a person who's had repeated trauma. Good questions. So what time are we at here?
10:30.
Okay, that's about the halfway point. Any other questions? Yes?
How would you approach somebody that you see that they have a symptom of mental illness, but that person, don't think they do have it?
Yes, I'm glad you asked that. That's going to come up more when we talk about the case studies in psychosis with Jackie. But one thing to keep in mind is with that Craig Rennebaum quote, just being present. Even if they don't want help, maybe they don't want to talk that day, but you could be around. You can just kind of even sit next on the bench. Sometimes I sit kind of down the bench and just kind of be there with the person. Let them know that I'm there, I care, I'm available, but I may not say much. That's okay. That's actually more helpful to that person than just walking by. Now some days when you see someone that's agitated and maybe aggressive, it's okay to walk by. But just log that in and observe it. That this person's having a really bad day today. And what I do sometimes, if I know the person especially, I'll say, hey, it looks like you're having a bad day today, you're upset. Can I check in with you another time? And the folks usually appreciate that. If they don't want to be bothered then, you can always say, I'll check in with you tomorrow. But I think if we all did things like that in our communities on our way into work, the city would be a lot different. But what you observe when you see folks come into work is they take a wide berth around someone who's hearing voices, and they don't offer anything. Or if someone's holding a sign, they don't offer relationship because they're thinking they're going to enable that person. I think there's a lot more we can do, and you guys, you get that. But that's some of what I encourage people from our churches to do more of. Any other questions? Okay, let's take a break.
Someone who does some employment and re-entry work. A really great team of people to work with, and I'm not just saying that because I work on that team. We're located now at 418 2nd Avenue Extension South in the Fortson Square area of the city, right next to the Lazarus Center, and that is my phone number. You can reach me at any time you feel you have the need to do so. If I'm not available, then leave me a message. I will be sure to get back in touch with you. Okay, so the 4 Ps. The 4 Ps are 4 factors, risk factors, and they are predisposing factors, precipitating factors, perpetuating factors, and protective factors. So Larry and I work for the most part with homeless adults or mentally ill adults in the city of Seattle. And many of you guys work with folks on sort of that front end. You're working with the juveniles and young people, so you kind of get to have contact with them at an earlier stage of life than we do. So I'm sure you're seeing many of the precipitating and predisposing factors, and some perpetuating as well. So sometimes by the time the individuals get to the Larry and I stage, they have experienced a significant amount of trauma. Larry talked about the ACE, the adverse childhood experiences. And what that means for individuals who have experienced those traumas, who have experienced long-term homelessness, experienced mental illness for a significant part of their life. So predisposing factors are the other ones that increase vulnerability and help individuals develop the psychological problems they may have. What would some of those be, predisposing? Anyone? Family, absolutely, family of origin, okay? And what kinds of family? Dysfunctional families, okay, dysfunctional family. So a dysfunctional family of origin. And the precipitating factors, the ones that trigger the onset or exacerbation of the psychological problems. What would some of those be? Yeah.
Threatening situation.
Excuse me? A threatening situation, absolutely. Perpetuating. The factors that maintain the psychological problem and prevents its resolution. Perpetuating factors, we see those daily. Homelessness, okay, well, absolutely, homelessness. Sex worker, okay, trauma. And then protective factors, that's the work that we do. The factors that prevent any deterioration in the condition, so we come and help folks develop protective factors. One of the things Larry spoke about previously was resiliency, helping folks develop resilience, okay? And then I also have here too as well, internal versus an external system. Speaking about the external system, those are things that we have some control over, whatever amount of other clients I may be working with. I believe that a way in which we can approach this thing differently and really get some significant outputs is by engaging, re-engaging family members back into that community. It is not our place to judge what someone's breaking point may be when it comes to dealing with someone with a chronic mental illness, okay? We're all human beings, and I think we all have a breaking point. But at times we assume this role, being an advocate and almost sometimes holding people away from re-engaging with relationships. You can't do it all, none of us can. And we should never be under these, we should never hold fast to those belief systems that we are you know, the only individual in someone's life who can help them. Reconnecting someone with family may be the best thing that you could do, okay? Causes of schizophrenia: genetics, physical illness and stresses such as viral infections or stressful events, and knowledge is still developing there too as well. And puberty, the disorder can onset during stages of hormonal changes, and as well chemical imbalances in the brain. Different types of schizophrenia: the paranoid type, which we see mostly here in the streets of Seattle, disorganized, catatonic, residual, and schizoaffective disorder, very debilitating as well. Because what you have the schizophrenia and a mood disorder occurring at the same time. Very, very debilitating. It inhibits one's ability to work, play, and engage in meaningful relationships. The thoughts are disordered and at times delusional. The speech will at times not be based in reality. The presence of hallucinations, auditory, tactile, and visual, okay, touch, hearing, and sight, possible eccentric behaviors, and address. Poor grooming and hygiene. Okay. Observations of individuals who are schizophrenic on the streets of Seattle. Larry, if you want to chime in at any time, okay. And that's become my passion. I know I've been here for a year and a half, and you know, you kind of find your way. And schizophrenia has become, never before had I been as passionate about schizophrenia as I am now working with folks on the streets, because it's just such a high prevalence of folks with schizophrenia who are on the streets. And the majority of them are not using substances. So they're not using substances, they may be engaging in petty crimes. These are folks who are homeless because psychologically they just can't function, right? So these are folks that I really care about deeply. Typically solitary individuals, usually disheveled in appearance with poor hygiene, reclusive and disinterested in social contact, non-confrontational, resilient in meeting their personal needs. So you find that these folks are still some way able to meet their needs. They go get fed and maybe take a shower sometimes. Resistant to efforts for relocation off the streets. They don't want to be relocated. If you're having persecutory, paranoid delusions, why would you want to be relocated? It could be the CIA taking you to some place to hurt you or harm you. Resistance to medical and psychiatric support. That one is really, really, really prevalent. You know, folks will have memories of, I just don't want to be on medication. Like, one of the first things they'll tell you is, I don't want to go to a place and I don't want to be on medication. And you're thinking to yourself, that's the one thing that can help you, you know? Larry, if you want to talk about that a little bit.
Yeah, I was just thinking, Stephanie and I were talking earlier about folks with schizophrenia are often housed. So I'm a fan of aspects of housing first. It's helpful, but for folks with schizophrenia who are housed, the isolation continues on. And we still see folks out every day in these locations, resistant to help, resistant to medications. But they have housing, so what can we do? We've done that piece. What's left? And I think the answer lies in a place where these folks feel needed, where they belong, where they can contribute some of their gifts and talents. Because what we find through the fog of the illness is everyone has gifts and strengths and talents as we get to know them. And we can talk about down the line of people we know who have talents. But we need a place where they can go. And hopefully that's coming to Seattle very soon. It's a program called Clubhouse International. It's designed as a psychiatric rehabilitation program for people with serious persistent mental illness to come and engage in life-giving activities, abilities rather than disability.
And it's one of the things that I'm most hopeful about. I work a lot with folks in the community who are mentally ill, whether they're diagnosed or not, or aware of their diagnosis, have any insight or not. And the Clubhouse is not a treatment center. It's not somewhere you go to get therapy. It's somewhere you go to re-engage, somewhere you go to feel affirmed and wanted. And I'm really excited about the prospect of Clubhouse coming. I think I have now at least 10 people in mind, so Larry saved me 15 spots. But I'm really encouraged about the prospect of Clubhouse in Seattle. I think it's a game changer.
So you said it's not therapeutic, or it's not designed to be therapeutic, but that is therapy that they...
Exactly.
It's not therapeutic in the sense of clinical.
Yeah.
Sure.
We're not talking about medications and certain therapies that are commonly used.
Yes.
How often do you observe with schizophrenia spiritual issues in that population? Because I think sometimes that can, obviously that schizophrenics sometimes have very spiritual experiences, and how do you how do you integrate those conversations, I guess, in your work, or think through those?
That's an excellent question. It's almost always you find that there's some sort of expression about, you know, whether that be God or spirituality. Almost always delusional. Individuals may see themselves as being God, or may have had a conversation with God. So, you know, there's a thin line you tread when you work with someone who's schizophrenic, making the decision to engage the delusion or not.
Right.
So what I do initially is, not knowing someone and having a relationship, I'll engage that delusion, because I just want to build a relationship and some trust. So if you think you're God, then I'll call you God for the first week or two, or depending on how long I'm meeting you. And then eventually when I build trust, I can challenge that. You know, so yeah, it's a thin line. Relationship, the relationship has to be the foundation of everything. If I don't have a relationship, I don't have the place to engage you in that manner. I really don't, to challenge that. Who am I? I'm just some random guy on the street telling you you're not God when you believed that for 10 years, you know? So, yeah. Good question, Mike. Okay, so generally misunderstood, perception of persecution or abuse, family and friends are frustrated. So this piece is really key. The frustration of family and friends, and sometimes providers. I mean, we get frustrated, right, Larry? Yeah, we get frustrated too as well. Okay, so treating it, psychotherapy, once again, talk therapy. Psychotherapy, medication is super important. We always advocate for someone to get on their meds and be compliant with medication. I'm working with a client now who was just prescribed medication. She is bipolar, diagnosed with schizophrenia too as well, has a homicidal ideation, was just prescribed medication that was making her super drowsy, but her body just not adjusted, so she would be sleeping for way longer than she wanted to, but we kind of talked about, hey, continuing or talking to your doctor about maybe reducing the dosage, but that it really helped her manage her symptoms. So she's continuing to be compliant, but based out of trust. You said, hey Jackie, you said to me I should, so I did. And you're always honored to hear those things, that someone trusts you enough, and that's a really delicate balance. It's a privileged position to be in when someone trusts your work. So what you do with that is super important. And of course, self-help. So Clubhouse is really a self-help model. You know, this is really a self-help model. It's an amazing, amazing model. Once again, game changer. Psychosis is a brain problem that is treatable. All right, Larry talked about, you know, it's good news that most of these disorders are treatable and manageable, and it affects 1% to 3% of the population. We talked about the warning signs, and early identification is key to successful treatment. So you guys on the front lines, you know, you're dealing with young people. Why am I observing? And that's why the assessment part is key. Assessment is key. It's everything. Persistent and untreated psychosis can result in schizophrenia, which correlates with homelessness. And then what has been successful? It's a 2-year duration of treatment focused on skill building, Larry once again, Clubhouse, including family intervention that educates the family on effective strategies. And it's called coordinated specialty care. So what you have is you have team leadership, you have case management, you have psychotherapy, supported education and employment, family education and support, pharmacotherapy, and a primary care coordinator who works on individual resiliency training. So see how comprehensive this thing is. And then as organizations, sometimes we try to work in a vacuum. Some organizations only providing case management, maybe some psychotherapy, families are uninvolved. This lady we're working with, her family member, because she's not a person who's tiered with our agencies. We work with her more than the agency does, but she's not a client of ours. So she's working with an agency in the city that refuses to talk to her sister, just completely unresponsive, okay? And then the need for introspection. This is burnout work. It's okay to admit being burned out, and equally all right to decide to pursue another vocation. I don't know how much time I have left doing this. Larry was saying he did this for 20 years. He's been a mental health therapist for 20 years. And I think some days about what I want to do next, to be honest with you. I think you have a good maybe 5-year intense stretch of doing something, and then, you know, because I mean, we're human beings, there's only so much you can take, you know, and that secondhand trauma can really affect you, okay? And we see it all the time too as well. The therapist or social worker must be in a constant state of reflecting on their work with the goal of identifying what's working and what's not. So once again, the mind stuff, their life, and what wholeness looks like, what loving well looks like, reflection and self-awareness, knowing who I am. My dad was physically abusive to me. So when I work with clients who may have had these experiences, I have to really check myself at all times, because then my stuff can get intertwined with their stuff, and I'm not helping anymore, okay? We're two wounded people walking towards not being well, okay? Housing first strategies. Even if homeless individuals with mental illness are provided with housing, they are unlikely to achieve residential stability. that residential stability is important. Many of the folks we work with have at one point in time or multiple times been housed. So Larry talked about this comprehensive wraparound service model for individuals. We can't just say housing first and leave it at that, you know? It's irresponsible. Yeah, it's irresponsible. So in addition to housing, programs offer services such as mental health, physical care, education, and employment opportunities, peer support, and daily living and money management skills. Okay, those things are really important. Wraparound services. Okay. So this is the case study for V. So I'm gonna read this stuff to you guys and I'll come back and ask you some questions. Okay, so you're assessing right now. You're assessing, you're taking notes. She's a 57-year-old African-American female. She's been homeless for some 10 plus years, I think 18 or 19. Fixed the delusion that her being on the streets is due to the delivery of a large sum of money owed to her. So someone's coming to bring me a large sum of money so I can't leave this area. So Larry and I are kind of hoping in some ways that the delusion is true and she'll give us some of that money, you know, but we'll see. So if you ever hear that Larry and I retired, that just means she got the money and she took care of it, okay?
Doesn't mean we're burned out.
No, yeah. We're finally well compensated for our efforts. She does not identify as homeless. When Larry takes her stuff, she says, why are you, there are people who are actually homeless here, you should help them, you know, not me. She has supported a sister who provides food items, but is frustrated with the system, the lack of communication by service providers, and persistence of the disorder. She's generally well-groomed, and that has changed recently. It's changed significantly. We'll talk about that. She will not receive or request anything from individuals that she's not bonded with. So Larry and I, she might get word to us and say, hey, I need some food. But if you're not bonded with her, she generally will not take anything from you or ask you for anything. She spends a significant amount of time making up her face, and that has changed as well recently. She has history as a cosmetologist, history of residence in an inpatient mental health facility. So for substance use, she denies. They're unremarkable. There's no signs of substance use. Mental health, or psychiatric, schizophrenia, paranoid type. Negative symptoms listed here. Positive symptoms listed. Medical, chronic back pain, foot pain, swollen feet, weight loss. She reports being diabetic and hypertensive as well. So you're thinking biopsychosocial assessment. What are we thinking? What are we seeing? What are we doing? Bio. What's bio here? Biological. And what things are here? Biological. Schizophrenia. That's foot pain. Exactly. Swollen feet. Right. Weight loss.
Yeah.
Okay. Perfect. Psycho.
Her delusions.
Yeah. Her delusions. Right. Her delusions. Her mental illness. Social.
Doesn't ask for help.
Doesn't ask for help. Isolated.
Has a relationship with her sister?
Relationship with her sister. Beautiful. Beautiful. All right. And then spiritual. We don't see any. But I think we may have discussed spirituality somewhat. Yeah, she doesn't believe in God. Yeah. So, this individual, what are we going to do for her? What are we doing for her to help her? How are we going to love her well?
Maintain the bond, build the bond stronger.
Maintain the bond, build the bond stronger. I love that. Yeah. Biologically, she has some biological needs.
Yeah.
How do we address those? This is Seattle too as well. She's on the streets. She's not going to go in with you. How do you address those needs in Seattle? This is real people.
Bring help to life.
How do you do that? Who do you call? APS, okay. And this is the conflict you're having. That is the reality of this work. She will not go in to get medical care. The mobile medical van, I think they went out and she wouldn't come out to see them. And there are medical doctors who are connected with the workers working with her who are concerned about liability, who are not really willing to engage. So she has all these medical needs that cannot be addressed. And that's significant. Let's store that away. Psychologically, what are we doing for her? Are we bringing her meds? Can't do that. She won't go in for a psychiatric evaluation.
Earlier you mentioned that at first when you know someone, you engage their delusions, and then
Yeah.
after the trust is built, you challenge. So
Yeah.
maybe it's time for you to, or after,
Yeah.
not advising that,
Yeah.
but like I'm sure now maybe might be the time of like, well, what if somebody doesn't come?
Yeah, beautiful. And that is beautiful work. That is and we've done that. We've done it and done it and done it, and there are days when she said, well, I thought they're supposed to come today. If they don't come today, we'll see. And we go back tomorrow, it's like, no. But beautiful. So for a year and a half of my time being here, and Larry a lot longer than that, and her sister, and we have a guy named Ryan Likes, and just an entire team of really skilled and loving people. I mean, we have tried every single approach. And this finally came down to us pursuing an involuntary commitment. You guys aware of how that system works, how that process works?
Yeah.
Okay, so I'll let Larry talk about the involuntary commitment laws a little bit since he loves them so much.
Thanks a lot. Well, I just want to say my approach with V, I don't believe I've ever engaged her delusions, but so I've kind of been the good cop. And as a rule, that's what I would suggest, is engage her feelings underneath, her distress. Talk about that all you want. But at times we need a hammer to come and be more direct and challenge. So with the involuntary process, that's what that is. It's very direct. There's no way around it. Folks come out, they're called CDMHPs, County Designated Mental Health Professionals. You can call them directly at 206-963-2300 from 8 to 5, and they'll come out and see a client, or you can go through the crisis line after hours. They'll come out to wherever you're at. It can even be on the street, which they did. I think it took a day or two before they eventually made their way out there, because V wasn't going anywhere. But, and that's not her name, by the way. They came out and just directly asked her some questions pertaining to her mental disorder. So they were looking for mental disorder evidence. And then the other key piece of evidence is grave disability. How is V not caring for herself in a way that jeopardizes her health and safety? And so when they heard reports from Jackie, from her sister, from others that there had been significant weight loss, that she was no longer tending to her needs, the hygiene was deplorable. They had enough evidence at that point to call EMS to come out and ask V to get on a gurney, which they did. And what was really amazing about it is my team happened to be out there right at that moment when they were there. It was just, you could say coincidence. I think it was providential, because some of my team members were able to ease that transition for V and just assure her, we're with you, we're right behind you, we're going to be there for you, we'll come visit you. And that helped. That helped it from becoming a confrontational scene. And then the process went on, and 72-hour hold. After 72 hours, those are business days, so that doesn't include the weekend. The team who wrote the statements to get her into the hospital, they provided statements, came to court. And this could happen to any of you if you agreed to write a statement for someone with psychosis who's gravely disabled or a danger to themselves. You could be asked to go and just testify. And all you're testifying to, you don't have to be a clinician, is just what you've observed, the changes, the distinct changes in ability to care for self. And it's a great thing to be able to do, actually, even though it's not easy. I'm not going to lie, it's not fun to go to court and talk about someone while they're sitting right there who doesn't agree with anything you're saying. And in some cases, this didn't happen this time, but in other cases, I've been in court, I've been flipped off in the courtroom, told to go to hell, things like that. But in the end, after the person was restored to better mental health, there was gratitude, there was thanks. So keep that in mind. But it can be a difficult journey, the involuntary process, but a necessary one. So we're prayerful that this will lead to stability, enhanced ability to care for herself. And so far, things are looking good. There's very, very little information we have, though, about her current status.
So for those types of population, what are the resources that are out there that you think are most successful in working with some of those clients? We've had people that have gone through the system like maybe 3 to 4 times, and they're still stuck, they're still around.
Well, they've been detained and then they come out. And, yeah. So.
there are specific programs out there designed to meet with people on the street where they're at. And one of the requirements is that they don't want help. So one program is called the HOST program with DESC, Downtown Emergency Service Center. That's their whole reason for existence, is to meet with folks with mental illness who do not want help. If they want help, then you refer them to another program. But as Jackie was saying earlier, resources are limited, and they're great people, but they have overwhelmed caseloads for sure. And so that's part of why Jackie and my team have come alongside to help. So you can call us too. If there's a person that's going in and out of the hospital, they don't want help because of psychiatric reasons, we'll come out and try to build relationship through time-rich engagement. That's something that HOST doesn't have the capacity to do. Don't tell them I said that, but it's true. But they're a great resource for psychiatric care and some of that ancillary support that we can offer. We do have access to psychiatrists, but it's a little bit more difficult. But what we do have is we have volunteers, interns, Jackie's staff to do time-rich engagement. And I think that's the key. You know, we were talking earlier about its presence. With these folks, it's patience. It's telling them that you matter. So you can call us, but I encourage you too to build relationship and encourage your fellow staff to build relationship, even if it's a brief moment during the day to get a cup of coffee or say hello. Those are some of the things you can do. It's going to take time. It's going to take a lot of patience, and it has. I mean, with V, how many years, Jackie? 18?
A year and a half for me, and she's been 18.
Yeah, 18 years, and that's ridiculous, but that's an unusual case.
And I think once again, this just underscores the reality of the issue that we're dealing with. Like, the mayor talks a lot about increasing homeless beds, and Larry advocates for that a lot too as well. Really appreciate his work in that forum. But once again, we're dealing with a system that is unresponsive, not only because I think we're not properly educated, but also because the resources are just not available. And then you have to make do with what you have, because what are you going to do? You're going to pack your bag up and go home and say the system's not working, or you're going to get upset and just be an angry, you know, individual or professional or practitioner. You know, we have to be dynamic. I mean, you have to think on your feet. I mean, my motto and my morale, our mission is to find ways to say yes. And that starts by, number one, being the best professional that you can be. And number two, networking and building relationships. We met Nicole because we found out about the program, we came and met with her, and we invited them to come to our MVT meeting, which is a group of practitioners in the city that get together on the first Wednesday of every month. And they came and they added another presence, and they'll be presenting at that meeting. We have to build bridges, because as single entities, we just don't have what it takes. That's the reality. I don't care how good you are as a practitioner. I mean, we just don't have what it takes. But at the same time, this goes back to the internal versus external system. When the external system says, we don't have any resources and all doors are closed, what do? You know, that's the test of who you are. You know, that's the test of who you are, and I love those challenges. I mean, I absolutely do. That is what, you know, defines you as a professional. You know, that is what defines you as a professional. When people say it's impossible, okay, can I reach out to Nicole? Can I reach out to another partner? Can I use my own personal funds to do this? I mean, there was a lady who we worked with who was blind and in a wheelchair at 2nd Avenue Extension, and all the agencies in the city we asked, no one could help her, and she was just, this lady was 70+ years old, living on 2nd Avenue Extension in a wheelchair with a guy who was financially abusing her. And I got upset for a while, I did. And I was raging against the system, and I realized, this is not benefiting this lady. It's not, you know? And we found a way, We've taken folks as far as Tacoma, we put folks in our van and driven them, you know, and sometimes you run the risk of going home with some bed bugs in your clothing and lice to your family and children. But this is what you signed up for. You know, no one said this was gonna be glorious and this was gonna be beautiful. It's nitty gritty, man. It's really, our approach has to be roll my sleeves up and get this done. We are intellectualizing human services. And I know there is room and there's space for the intellectuals in this field, but at the end of the day, there have to be folks who are willing to roll up their sleeves and go get it done. Not looking for any glory, not looking for any recognition. Get the job done. as best as you can. Okay? All right, that's my next one. So we've talked about mental illness, psychosis, psychotic disorders, and homelessness correlation. And another one is substance use disorder. The traditional homeless guy was a Vietnam vet, a World War vet, came home and was dealing with PTSD and trauma, just unable to cope and found himself homeless. Someone down on their luck, lost a job, was homeless. Poverty issues. Increasingly, we're seeing two real significant factors: mental illness, chronic mental illness, and this here, substance use disorder. So let's talk about that for a little bit. So the DSM-5 has changed the categorization of substance use disorder. It was once substance abuse and substance dependency. Now with the terminology, it's just substance use disorder. And there are criterions for that: impaired control between 1 to 4, social impairment, risky use, and the pharmacological criteria, which is 10 to 11, the most severe. So this is a graphic that I have from a conference that Larry and I actually went to together. A really good bonding experience. Larry, myself, and Trevor, another one of our workers, we went out to Yakima for this conference, and we just had some time to really learn and be poured into, because you spend so much time giving out, and we had some time to spend together as brethren and friends. It was a really good experience. We came back, I think, refreshed with some information, and this I was really armed with, I feel like. I really took a lot from this. So, substance use amongst US adults. And as you can see, you have 2.3 million in treatment, 23 million who are in active addiction, and 40 million who are using harmfully. Okay? In America, only 10% of adolescents who could benefit receive substance use treatment. Is that surprising? That only 10% of adolescents who can benefit are receiving substance use treatment? And the juvenile justice system pays for the majority of that treatment. Harmful use exacerbates or predisposes for other medical conditions that cost $80 billion to treat. So harm reduction, you think in harm reduction wise, $40 million is spent yearly to treat those in treatment. So it's saying that we spend $40 million yearly to treat those in treatment, and we're spending $80 billion, or $80 billion is the effect of folks who are using harmfully. Individuals assessed as using harmfully are not in treatment. To the contrary, 1/3 to 1/2 of individuals receiving treatment in seizure clinics have pseudo-seizures. What we're saying is pseudo-seizures we believe and we treat it as if it is a significant issue, but folks who are using substances harmfully, not necessarily so. And the youth in treatment, 2.3 million in treatment, 23 million addicted, and 40 million are harmfully using. 60% of substance users will have a diagnosed mental health disorder, so comorbidity, co-occurring disorders, and an integrated approach to treatment works best. Adolescents are more vulnerable to substance use disorders and mental health disorders, and half have an onset before the age of 14, 1/4 before the age of 24. Once again, this is your population, young people, very young people. Childhood mental health problems increase the risk for adult substance use. So mental illness in adolescence and childhood or traumatic experiences increase the potential for adult substance use. Regular use of cannabis during adolescence shaves 6 to 8 points off your adult IQ. That could be the difference between a scholarship or no, right? I think. It also quadruples the risk of psychosis, and these numbers are reminiscent of the effects of lead poisoning, which appears to be addressed more seriously than interventions for rampant cannabis use amongst adolescents. Exposure to marijuana prenatally has been shown to cause deficits in short-term memory, learning ability, verbal and abstract reasoning, and depression, and this may kindle the brain to predispose to addiction. And this is a Colorado report, but very close to what we have here in Seattle, that IV heroin use has quadrupled in Colorado, and 80% of the individuals polled report having started with the use of non-prescribed cannabis and non-prescribed opiates. Daily cannabis use is at a 30% high. 10 to 15% of high school students meet the diagnostic criteria for cannabis abuse.
This material was presented by a medical researcher in Colorado, psychiatrist.
Child psychiatrist, yeah.
She's just presenting what she sees.
So the concept of rock bottom, we all often talk about an addict or an individual having to hit rock bottom. I think it's a fallacy. And abstinence should always be the goal. That was the word, abstinence. What do we think about that? Abstinence should always be the goal. Yes or no?
Yes.
Yes? Pro-social relationships and pro-social activities are important. Therapeutic approaches, including cognitive behavioral therapy, have been proven to be effective. And then the most effective model, cognitive behavioral therapy coupled with motivational enhancement therapy and contingency management, a reward system. Where right outside of our doors of our new office is what they call Crack Beach, colloquial term. There are a lot of African American individuals by the age ranges of maybe 40 all the way up to late 60s who have been engaging in crack cocaine abuse, crack cocaine use for years. And we're thinking about starting a group to talk about addiction, talk about recovery, but we want to make it contingency based. But in dealing with folks who are using crack cocaine and we understand what comes with that disorder, we're thinking about what can you provide as a reward that they can't take back and sell to feed the habit, okay? So if you guys have any thoughts, I would love to hear that. McDonald's gift cards, no. T-shirts, no. You know, so we're thinking about it, but what has no street value, you know? So contingency reward, contingency management program, okay? In one study, 70% of kids on Prozac remitted and 52% treated with MET and CBT method remitted. So with no medication, CBT and MET, 52%, pretty good success rate there too as well. Okay, so the importance of a holistic approach. The legalization of cannabis is labeled to be madness. I know people have thoughts about that, but it's labeled to be madness. And at the core of the issues that we label mental illness and substance use disorders are real people who have suffered adverse life experiences and who need care in all areas of their lives. Therapy without medication is actually proven to be successful. The belief that an addict has to hit rock bottom is cattle dung. She uses some very colorful terminology. I really love that lady.
Tell me how you feel.
We need to invest more, including dollars, into early interventions. What are our thoughts about legal cannabis?
I love that it decriminalizes the use.
Okay.
Yeah, just 'cause
So folks are not going to prison for the use of cannabis, so we love that.
You can finally research it.
You can finally research it. Okay.
I think it's like alcohol, and the use of it is, it's not the substance itself.
Okay. And what about our young people and the use of cannabis? What conversations are we having? Are they the same? Have they changed?
Yeah.
They should change? How so?
Just because of the rapid increase in addiction
Okay.
for teens and
Okay.
adults.
Yeah. And we see a correlation between adolescent cannabis use and adult substance use disorder too as well, okay? All right, why do people use drugs? Environmental factors, peer pressure, emotional trauma, PTSD, experimentation, biological and psychosocial factors. Okay. So Richard O'Connor also presented and he talked about self-destructive behavior. We see that in young people and the roots of self-destructive behavior. And he says addiction can be symptoms of deeper untreated issues, and he talks about something called a rotten childhood. Someone talked about family of origin. A lot of the work we do starts with family of origin. One of the questions I love to ask folks on the street is, what about your family? Tell me about your family. And more times than not, you see screwy face stuff. I don't want to talk about them, or I don't care about them, they don't care about me. But one of the things we love doing as well, a component of our program, is just reconnecting folks with the family of origin, the family support system. So it's like, hey, can we do some reconciliation work? And we get on the phone, maybe, or have a family member come over, and we try to see and determine if the family will be willing to sort of reconnect and reconcile, and then, you know, we just get them back to the family, all right? So rotten childhoods can lead to damage and destruction of the brain and loss of the adult's ability to regulate emotions and to focus. And the converse is also true, that with enough practice, the brain can be rewired, especially with the young people. The brain is just so plastic, okay? The conscious self has a lot less control of our actions than we would like to believe. So a lot of things are subconscious. And self-destructive behavior can also be the result of our two minds not working together, the conscious mind and the subconscious mind. Okay, so the presence of childhood trauma is usually an indication of defense strategies. Self-destructive behaviors do not happen in a vacuum and have perfectly good explanations. Be conscious of the language you use in therapy and caring relationships, and you're also teaching the client emotional vocabulary. I'm angry, I hate them. Let's unpack that. What does that mean? Let's get down to the deeper meaning of those things. Okay, emotional vocabulary is super important. 7 drug categories. We'll skip past that and just talk about some specifics. What are the drugs that are very prevalent here in Seattle? Heroin, meth, alcohol. Okay, heroin, meth, alcohol. Huge issues with meth. So stimulants, drugs that stimulate the brain, and central nervous system, speeding up communication between the two. They increase alertness. All right, and also caffeine is saying that caffeine is also a stimulant. And these are some stimulants here. I have methamphetamine or meth highlighted. Significant issue with methamphetamine. What does methamphetamine, intoxication look like on the streets or in here? What does someone who uses meth look like? Are they sleepy, drowsy, trying to go to bed?
Really active.
Really active?
They're active for
Superman.
days.
Superman,
yeah.
yeah.
Then they crash.
Yeah. Go, excuse me? Then they don't sleep, exactly. So Larry talked about the perception of